Welcome and thank you for joining us for this webinar presentation. We are the Homeland Defense and Security Information Analysis Center, or HDIAC, one of 3 IAC domains in the DoD Information Analysis Centers operating under the Defense Technical Information Center, DTIC, within the Office of the Undersecretary of Defense for Research and Engineering. Our informative webinar series highlights current and emerging research and technology developments. It presents an opportunity for accelerating the DoD's leverage of these advancements by increasing awareness and fostering technical collaboration. HDIAC serves as one of the premier information research partners and curators of technology advancements and trends for the Homeland Defense and Security community. As such, our organization supports those working in the Homeland Defense and Security domain of DoD research and engineering. We do so by helping navigate the vast landscape of scientific and technical information, allowing our customers to get a head start on their technical projects. With an understanding of the Homeland Defense and Security DoD research and engineering landscape, we provide research and analysis services. We help unlock access to information, knowledge, and best practices from government, industry, and academia to stimulate innovation, foster collaboration, and eliminate redundancy. We hope you enjoy this webinar presentation and that it serves as a catalyst for community collaboration and improved DoD Homeland Defense and Security research.
Okay, good day, everybody. My name is John Clements, and I'm the technical lead for HDIAC. And I'd like to welcome everybody to part 4 of HDIAC's Brain Health mini-series. We are presenting this mini-series in addition to our regularly monthly webinars. The goal here is to highlight the tremendous amount of research into the health of the brain, which is the most complex organ in the body. Decades of research by thousands of people worldwide has led to an increased understanding of how the brain functions and how it impacts our operation when it is injured. However, with each answer, multiple new questions seem to arise. So part 1 of the mini-series started in the beginning, discussing the SABRES program and baselining for the brain. And that was presented by Drs. Amy Baer and Catherine Starnes. Part 2 explored the mental health of soldiers and their families who have not deployed and may suffer from a type of survivor's guilt. And this took place in May, which was Mental Health Awareness Month. And that webinar examined a longitudinal study done with hundreds of soldiers and their spouses. In part 3, we welcomed back Drs. Baer and Starnes to discuss neurofeedback, or NFB, and methods to modify brainwave activity to the benefit of the warfighter. And finally, today, we examine methods of using cognitive and oculomotor functions to assess service members who have suffered a traumatic brain injury. If you missed any part, you can check them out on our YouTube channel, and the slide presentations are posted on the HDIAC website. You can just go to hdiac.org/webinars and find the webinar you want, and you can download the slides as well as link to the YouTube recording from there. And with that, I would like to introduce today's webinar presenter, Dr. Mark Ettenhofer, who is a senior research neuropsychologist for the Defense Health Agency Traumatic Brain Injury Center of Excellence, or TBI COE, at the Navy Medical Center, San Diego. He also serves as Associate Professor of Psychiatry at the University of California, San Diego, and the VA San Diego Healthcare System. He has served as Principal Investigator on multiple federally funded projects evaluating novel technologies for assessing and rehabilitating TBI. His work has been published in leading journals in neuropsychology, psychiatry, neurology, and rehabilitative medicine. Dr. Ettenhofer's ongoing research is supported by TBI COE and the Congressionally Directed Medical Research Program. And with that, Dr. Ettenhofer, I will turn it over to you. And I can see your slides, but if you're talking, I think you're still on mute.
Okay, here we go. Got the microphone figured out. Good morning to everyone out here on the West Coast with me, and good afternoon to everybody out in Eastern time zone and beyond. Thanks for that great introduction. I'm really honored to be able to provide this webinar today to talk about some of the research and clinical activities we've been working on in support of the Defense Health Agency Traumatic Brain Injury Center of Excellence. So we already had the introduction here, and so I'll be sharing with you a lot of research related to one of the clinical areas that I'm most passionate about, which is finding ways to improve assessment for traumatic brain injury in service members and veterans. So standard disclosures and disclaimers apply. Any views expressed are those of my own and not of the government or Department of Defense. And some of the technology we'll be talking about is covered by patents, in this case, patents owned by the Department of Defense. To give a quick overview, I'll be starting off with some traumatic brain injury basics, talking about effects of injury, prevalence of injury, and what recovery tends to usually look like. And then we'll transition to talking about assessment of brain injury, the current capabilities and the gaps in those capabilities that drive us towards wanting to find new ways to do things. And that's where some of our research comes in. So I'll introduce eye movements and why eye movements are so central to a lot of the brain assessment work that we've been conducting, evaluating oculomotor and cognitive networks. And I'll take you on a bit of a tour of our neurocognitive eye tracking capabilities that we've developed, along with scientific validation of those approaches and ongoing research that we're conducting in the Department of Defense to help push those forward. And then we'll have a summary and some time for discussion at the end. So traumatic brain injury, for those of you who aren't familiar, is any traumatically induced change in brain function. The brain is a soft, delicate organ, kind of like the consistency of a Jell-O jigglers. And as you move around in your daily life, the brain moves as well. And there's some normal amount of sort of jiggling and stretching that can occur during any kind of physical activity that you're involved in. But when the head or the brain is subjected to sufficient force, whether that's from a blunt impact, like the head hitting something or something hitting the head, a blast force, like breaching a door, firing shoulder-mounted weapons, or a bomb or mortar going off, or rapid acceleration, deceleration, such as in a whiplash type situation, the amount of jiggle or stretch that the brain can sustain can exceed what it can handle without injury. And some of the most delicate areas in the brain are the white matter, the sort of the wiring of the brain, which can stretch and get damaged in the process. Now, as you can imagine, given all the different physical forces that can cause brain injury, there's a lot of different locations where this injury can occur. There are some areas that tend to be more likely to experience neural injury just due to where they are in the brain and the types of forces that tend to be subjected to the brain. But at the end of the day, we don't know exactly which neurons are injured. And for any given patient, their pattern of injuries might look quite different from another. And so this is one of the reasons why it's important when we're evaluating traumatic brain injury to make sure that we get a good profile of brain system function. We need to evaluate multiple different cognitive and motor systems to do this. And this is one of the reasons why there's no silver bullet for understanding brain injury. There's no one metric that could capture the diversity or the heterogeneity that you get in terms of different types of brain areas that could be affected. So here's some of the potential effects of traumatic brain injury. Cognitively speaking, we often see patients having impaired attention, problems with executive functions like planning or controlling behavior, slowing of processing or psychomotor speed, and potentially issues with memory, recall, or encoding of new memories. Sensory symptoms can include things like dizziness, poor balance, problems with vision or eye movements. And so you're seeing a little bit of where vision comes into play here. This is a little foreshadowing. Some of the physical symptoms include things like insomnia and headaches. And emotional symptoms are also very common, things like irritability, depression, and anxiety. Now, as you can imagine, any of these symptoms could be caused by a very wide range of factors. So brain injury is certainly not the only thing that can cause these types of issues. Things like post-traumatic stress, pain, other medical conditions, aging, other forms of regular operational or life stress These types of factors can also have a big effect. And so that's a big part of the challenge with understanding what's going on with an individual with brain injury, is understanding the backdrop that it's on. And by trying to piece these things apart, we can try and best plan treatment for a given patient. And from the perspective of the Department of Defense, it's very important to make sure service members are doing well and feeling well, but it's also really important that they're able to do their jobs. And so one of the impacts that we're really interested in is trying to understand how brain injury can affect operational performance. And this can be really critical to planning return to duty after injury. Here's a chart that outlines the overall way that DoD and VA grade traumatic brain injury severity. So TBI is not graded based on sort of memory or cognitive function or the symptoms that somebody's having long after injury. The severity grading is made based on a few characteristics, neurological characteristics at the time of injury and how long those lasted. So I won't go through this in too much detail, but basically we're talking about how long you've been knocked out, loss of consciousness, how long you might have been dazed or confused, which is known as alteration of consciousness, and how big of a hole you have in your memory, which is known as post-traumatic amnesia. So for folks with mild TBI, also known as concussion, they generally have loss of consciousness under 30 minutes, alteration of consciousness less than a day, and post-traumatic amnesia for less than a day as well. And greater severity has longer durations of those factors. But one of the things that's come out in the research is that this severity grading leaves a lot to be desired. It does give an indication of overall characteristics and overall approaches to care. But within each of these categories, you have a lot of heterogeneity as well. So you can have plenty of mild TBI individuals who recover pretty much 100%, and some others who go on to experience chronic issues. And then you have plenty of individuals in the moderate to severe range who recover quite well, and others who do not. So the severity does not tell us everything we need to know. In terms of overall prevalence, this slide here highlights how critical this issue is for the Department of Defense. This is really a worldwide issue in all communities, but within DoD, you can see that since the year 2000, we've got almost 500,000 traumatic brain injuries that have been documented. The vast majority of these are mild in this setting and in most other settings as well. And then we have 11% that are classified as moderate and smaller percentages that are severe or penetrating injuries, and a small chunk that aren't classifiable due to limited information. But it's important to note that traumatic brain injury is not restricted to the combat environment. Even during wartime, a huge proportion of brain injuries are occurring through things that can also happen in other settings. Car accidents, accidents on the job, falls, injuries related to participating in sports. These are things that in our current society happen really no matter what setting that you're in. And the population of service members is a higher risk population than a lot of other ones just due to their level of activity. So what does traumatic brain injury recovery look like? And this is really important for understanding why we need improvements in our approaches to treatment and why this is an important clinical question. In mild TBI, what you can see here is that in the first week after injury, there are some detectable deficits on neuropsychological testing. These are things like paper and pencil tests, and that these tend to resolve over the course of weeks to months, where by 90 days after injury, the average concussion patient is performing normally on cognitive tests. So that's good news. Most people are experiencing a lot of really positive recovery at that level of severity. Not everyone, but on average. In the moderate to severe category, things are a little bit less rosy. The level of impairment is higher to begin with, and the amount of recovery tends to be less on average. But like I said, I've seen plenty of patients with moderate to severe injuries who are also performing, after a period of recovery, normally on neuropsychological testing. So this graph shows overall trends from a lot of different research kind of rolled together rather than what any given patient will experience. And here's what recovery from mild TBI looks like in terms of symptoms and activity. Basically, symptoms tend to go down over time, and level of activity takes a hit at first, but then goes back up. At first, the vast majority of individuals with concussion are experiencing clinically significant symptoms. After 3 or 6 months, that's in the range of 20 or 30-ish% of individuals who are experiencing symptoms. And this is actually higher from what we've found than what you see in some other populations. So importantly, you do still have a significant number of individuals with a history of concussion who are reporting symptoms into the long term. And so that's something that's of concern to us in terms of clinical care. So what are the current approaches to traumatic brain injury assessment? Well, really the primary driver of care and the main thing that's occurring in most clinical settings is patient self-report. This is either surveys or interview, what the patient tells you. So this is obviously very important for almost any medical condition, how a patient is feeling, what they're reporting. But unfortunately, it's very subjective and non-specific. So those patient-reported symptoms, particularly the further out you get from injury, can be very strongly influenced by life factors and things that aren't necessarily driven by how the brain recovery is going. And so this can be pretty limited in terms of giving us guidance about what kind of clinical care somebody might need. There's a number of other methods as well. Neuropsychological testing is considered the gold standard for traumatic brain injury assessment, but this is usually restricted to cases where they're either more complex than typical or there's special concerns at play, maybe someone who's reporting chronic symptoms beyond what you would expect at the mild TBI stage. It is more common for moderate and severe traumatic brain injuries to do this testing as part of standard care. The problem with neuropsychological testing, as I'll admit as a neuropsychologist, is that it's lengthy and time consuming, both in terms of the patient's time and in terms of the provider's time and the amount of providers there are to go around. So there's really not enough neuropsychological care resources available to perform full neuropsych batteries on every concussion patient. So this is something that doesn't meet all the needs of concussion assessment. Also, one of the things that I showed you a moment ago is that after 3 months, the typical patient, even on these evaluations, is looking pretty normal. So in terms of the less chronic setting, the more acute setting, there are a number of screening approaches like the MACE-2, the ANAM, and the SCAT, depending on the setting that you're in, that can be valuable for identifying problems that people are experiencing soon after injury, like sideline assessment or field assessment. But the issue with these is that they tend to lose sensitivity after about 7 days post-injury for concussion. And so that's a range where there may still be some significant impairments at play. So the screening function doesn't extend all the way into the chronic stage. Now, many people will think neuroimaging can provide a complement to this, and imaging does have a place. In the mild TBI or concussion context, it's mainly useful for ruling out other more serious forms of injury that could be life-threatening. Like if someone had a brain bleed that requires neurosurgical intervention, that's important to know right away. In more severe TBIs, imaging can also help to identify injured brain areas. But in mild TBI, neuroimaging, clinical forms of neuroimaging typically look normal. And so this is not clinically indicated for most concussion patients. So what do we need in order to continue to advance brain injury assessment? We've got some gaps here in terms of understanding why some of these patients are experiencing persistent problems and some aren't, and then in providing the right care to the right patient. Well, we need measures that are sensitive and specific so that we can detect subtle forms of impairment and not be mixing those up with other sources of impairment that aren't necessarily related to brain injury. They need to be multimodal or multi-domain to assess multiple brain systems, knowing that every brain injury could be different from another one. They need to be clinically feasible and scalable so that we can provide care to the very large number of individuals who are sustaining brain injuries and will continue to do so over time. And they need to be, most importantly, objective and scientifically validated. until we've done studies to know how a certain instrument or technology performs at understanding either brain function or brain structure or other relevant outcomes, then we don't yet know what to do with it. And that's an important process that we spend a lot of time working on so that we can use the measurements that we get to guide treatment and return to duty decisions in an objective way. So why eye movements? I know as a neuropsychologist, eye movements was not a focus of my training until this was an area of research that I picked up during my postdoctoral training. And so eyes function in some really unique ways that offer properties that are really advantageous from the perspective of understanding brain function. When we think of most motor movements, most muscles of our body are designed to provide output so that we can influence objects in the world or move our bodies around in the world. The eyes are, in contrast, providing an input function. They're guiding the sensor of your eye to collect visual information from the world. And from that perspective, the way that the brain utilizes these motor movements is quite different, and the brain networks differ substantially. The eyes are also very tightly tied in with central nervous system functioning, and the retina is really part of the central nervous system. So the neural pathways are shorter in many cases and faster. So eye movements typically are faster than a comparable hand movement, let's say. Eye movements are also, in many cases, much more automatic than the typical body movement. When we move our body, in many cases, we're doing it intentionally and consciously. With our eye movements, usually they just sort of happen automatically, depending on what we're interested in the visual environment. And when you look at things psychometrically, if you look at what eye movements versus other body movements are related to, in comparison of like an eye tracking test, let's say, versus a button press computerized cognitive test, the button press tests are strongly impacted by a very wide range of factors. Things like age, intelligence, depression, motivation, each have a very strong impact, even on simple things like someone's reaction time in pushing a button to a visual stimulus. Whereas eye movements, in comparison, are less influenced by a lot of those issues. And so it becomes maybe a more convenient way to capture a signal that is related to brain function, where we don't have to tease out quite as many demographic and individual factors. And this is particularly relevant when we have patients who are not average. So for example, in the special operations community, you tend to have people whose manual reaction times are way faster than the average person of their age. And so if they take a test based on manual reaction time, they're in many cases going to look really good, even if they've had some significant changes. Eye movements offer some remedy to that issue. So here's some of the basic types of eye movements that are relevant to today's discussion here. There's rapid saccadic eye movements, are where your eye is darting around and jumping from point to point, which is something that your eyes do, for example, when you're reading. And these are really the most prevalent form of eye movements as you're looking around your environment. Your eye is jumping around and you're not even really aware of the jumps. You're just aware of what your eye lands on, and that's what you see. Smooth pursuit eye movements are those that are involved in tracking a moving target. Like if you watch a bird fly through the sky, you're going to probably use smooth pursuit eye movements to track it as it moves. And then we've also got pupil dilation and constriction that occurs in response to a range of factors. Most people know that your pupil dilates when it's dark and constricts when it's brighter, just so that kind of like the aperture of a camera. But one thing that's really valuable from the perspective of brain assessment is that pupil dilation also relates to things like alertness, interest, and cognitive load. So this can give us an index of cognitive processing in an individual beyond other factors. There's other forms of eye movements as well, like convergence and divergence, but those are not quite as relevant to what we'll be talking about today. So let's look for a moment at the brain systems that are serving eye movements. So the superior colliculus, that SC at the bottom of the brain here, is what triggers a lot of saccadic eye movements. That's the sort of the basic trigger for eye movements. But what often is ignored is all of the inputs to superior colliculus and the brain networks that really are relying on in order to perform eye movements in real life settings. So you've got all kinds of feedback loops from anterior and posterior areas to those areas that actually trigger the eye movements. And this includes anterior areas involved in top-down conscious control, like deciding what kind of information you need from the visual environment. Inhibiting attention to distractors is really critical. Predicting what's going to happen next, like the Wayne Gretzky saying about skating to where the puck is going, not where it is currently. Your eyes need to be able to predict, your brain needs to be able to predict what's happening if you're going to be able to keep up in terms of your eye movements. And there's a lot of posterior areas involved in bottom-up automatic processing as well. This helps us to identify relevant targets in the environment, to orient to them spatially, and to understand the spatial relationships between different objects, to be alert, as well as other areas that I haven't highlighted here that are involved in memory. And really every cognitive area has some influence on eye movements. And this is something that is easy to ignore because in a basic eye exam, we try and rule out and eliminate the influence of those factors and just look at motor functions so we can see if the eyes can move and the basic eye functions are intact. But in neurocognitive eye tracking, as we'll be talking about, the goal is really to look at the influence of all these brain systems on eye movements so that we can index those. So the work that we've conducted out in San Diego is based a lot on this neuroanatomical model of visual attention developed by Michael Posner and colleagues, initially largely in the context of ADHD, or attention deficit hyperactivity disorder. But they did some work mapping out different attention networks of the brain that can be separated using cognitive cues. Now, Posner and colleagues did not focus on eye movements at that time, but this is something that we've borrowed and implemented within our eye tracking paradigms to be able to understand brain function using eye movements. So the first eye movement task that we developed out in Bethesda is the Bethesda Eye and Attention Measure, the BEAM. And in this eye tracking task, there's white circles that are popping up to the left and right, and the patient just needs to look at those and press the button on the side of the target. But the key that makes this different than sort of standard eye tracking here is the cognitive cues. We've got arrows, white arrows or red arrows, that provide cognitive stimuli for a split second before that target appears. And that's enough to make a big impact on their performance and to add some cognitive variance that ends up being really valuable. And I'll show you that in a second here. So here's an example of what the eye movements look like when somebody's doing this task. You can see that the target, the cues are popping up in the middle, and they're looking at the targets, and they're also pushing a button. When the white arrows are popping up, they look at the target and push the button. But when the red arrow pops up, as you'll see in a second here, they're not supposed to look and they're not supposed to push the button. That can be difficult. And what the computer is doing as they're doing this is scoring every single trial for how fast their saccadic response was, how fast their manual response was, different errors that they may have made with their eyes or their button presses. And so although this is a very simple task for a patient to complete, it gives us a wealth of information over the course of many trials. You'll notice that the cues are popping up very quickly before the target. So that's the timescales that we're talking about here. It's usually about a quarter of a second or less that they can see that before the target appears, and that ends up making all the difference. After developing the BEAM test, we found, as I'll show you in a moment, that the most cognitively loaded moments of the task were the most important. And so we decided to take this a step further and ramp up cognitive load using something called the NBAC paradigm, where essentially we've introduced working memory to the test, where instead of pressing buttons based on just the location of the target, now they're pressing buttons based on whether the color of the target is the same or different from the previous target. So they have to remember the previous target and then compare the color to each subsequent target as they're pressing their buttons. It's actually quite straightforward, and almost any patient that can do any testing can complete this successfully, but their performance does not end up being equivalent, and it ends up being a very sensitive way to assess impacts of brain injury. So I'll show you that in a moment here. In terms of the hardware sets that we've used, this is also something we've put a lot of effort into developing over time. Our initial systems that we developed back in 2010, 2011 were desktop systems. You can see the screen and the eye tracker there. What you're not seeing is the multiple desktop computers and postdoctoral fellows hovering behind, fussing, and making adjustments on the fly. So this was a laboratory setup that took a lot of work, but was useful at gathering some really valuable data that we used to help move things forward. Beginning in 2015, we began using a laptop system that we could deploy at Naval Medical Center San Diego in testing rooms that are used by neuropsychological staff to do testing of other sorts. So we would pack it up and put it away and then pop it out when we needed to do assessments. And in some cases, as you can see in the photo, we would collect other measurements too, like EEG at the same time. The problem with the laptop system, though, is that it still would introduce some variability from the lighting conditions of the room. And if the patient was distractible, they might be looking around the room and not necessarily focused on the screen. Beginning in 2018, we began using a wired VR system that really blocked out the majority of light from the rest of the environment. And this was something that we could use even in rooms that weren't set up for neuropsychological testing. Even in sort of a cluttered or busy environment, the VR headset would allow us to collect the eye movements and deliver the tasks without having to worry about those factors. Around the same time, we began working with the Naval Health Research Center to begin to import a lot of these methods and approaches into immersive VR environments so that we could begin to understand how similar sorts of eye movements could be at play in military operational type of settings. Because it's one thing if somebody's impaired on a clinical eye tracking test, it's another thing if they're impaired in performing sensitive duties like a foot patrol engaging targets. So you'll see what that looks like in a moment. And currently, we're most focused on platforms that are wireless mobile VR headsets that are quite inexpensive and really easy to deploy and block out a lot of environmental stimuli. And so we can see that the hardware platforms keep advancing to be more mobile, provide better control, lower cost, and more usability in clinical settings. In terms of the types of things that we're measuring here, I mentioned earlier about the multimodality and the multi-domain measurement that's important. So you can see in the beam and NBAC tests in the table here that we're getting a range of different cognitive domains, including psychomotor speed, inhibition with those red arrows. Remember, with the red arrow, when they see that, they're not supposed to look or press the button. So that measures inhibition, whether somebody's able to stop themselves from looking at a target, which is kind of a reflexive response. We also get spatial orientation. When the arrow is pointing toward the target for a split second before the target appears, in a healthy brain, that will facilitate performance. They'll be faster and more efficient. On the other hand, if the arrow is pointing in the wrong direction, that provides a little bit of misdirection and cognitive interference that the patient has to overcome before they get to the target. So that is a form of cognitive load, executive performance. And as I showed you in the NBAC task, we've also got working memory and cognitive load that we can modulate that way. And across any of these tasks, the pupil response can also provide some really valuable data about cognitive resource allocation and alertness and factors like that. So here's an example profile from the beam test. This is from a normal individual. In fact, I think no, these wouldn't have been my data, but these are from a healthy individual. On the left, you can see the saccadic responses. The blue is the responses of the examinee, and the green is their expected performance. So you can see this person's saccadic speed is right in line with expectations, and the error bars, the variability of their response or consistency of the response, is also similar to expectations. Their manual responses are a little bit slower than the saccadic responses, as we would expect, but also in line with expectations. And they've got on the right panel some saccadic no-go errors, but not too many more than we'd expect. And they've got 0 manual no-go errors. That part is actually pretty easy, not pushing the button when you're not supposed to. But you can see an illustration here that the saccadic response is harder to inhibit than the manual response. That's one of the keys to making this work. In this score sheet here, this is a mild TBI profile, an example profile. And in this case, the saccadic responses in blue on the left are slower and less consistent than we expect. And the consistency is actually the most hallmark sign that we tend to see in this population. Less consistent responses are potentially indicative of neural processing issues. But their manual reaction times are actually looking quite normal. That's actually very common in the settings that we see where their manual RTs are doing just fine. Their saccadic errors, in this case on the far right, are elevated. Their manual errors are not elevated. So this gives you a little bit of a flavor of the kind of things we'd be looking at in a clinical profile. We've conducted a number of validation studies over the years using the different prototypes and in different populations. In some of our early work, we saw that individuals with one or more mild TBIs, particularly if they had persistent symptoms, were much more likely to be impaired on saccadic metrics. Whereas in the purple, the conventional neuropsychological testing was not discriminating between these different groups of mild TBI and in healthy individuals. We followed that up with a study using the NVAC test, where we included a moderate to severe TBI group. And what we saw here was a dose response effect where the increasing level of TBI severity was associated with increased level of impairment on the fusion eye tracking tests. And then on the right panel, you can see a more recent study that was conducted using our laptop prototype system in San Diego. And the blue, purple, and green bars are from the eye tracking test, which showed significant ability to separate control and chronic mild TBI groups. The yellow line there represents the neuropsychological battery. So once again, showing that even among individuals with normal performance on conventional cognitive tests, the eye tracking still appears to have something to add here. In terms of how this works, I really wanted to drive home the importance of the cognitive load. Here we've got the different saccadic responses broken down by cognitive load and by cue type. And I won't dwell on this slide for too long, just in the interest of time, but you can see that in the far right panel, the misdirectional cue, that's when the arrow is pointing in the wrong direction and provides a little bit of what a former graduate student called trickeration, makes it a little bit more difficult. And that one is the most sensitive to differences between control, mild TBI, and moderate to severe TBI, particularly in that higher cognitive load condition. In the uncued condition, which is, you might consider that a classic pro-saccad type of trial, only the moderate to severe TBIs really differed from controls on that. So the cognitive load is key to eliciting some of these effects. We've also done some research just looking at how this performance lines up with other cognitive tests in clinical environments. So these are data from TBI clinic patients at Naval Medical Center San Diego, in data acquired in clinical environments. In blue, you can see the neuropsychological test performance. These patients, even the ones who are coming to clinic reporting problems, are on average doing reasonably well on their cognitive tests, those classic cognitive tests. In green, you can see the manual responses to the beam test. Those are actually looking okay too. But in red, you can see the saccadic responses, which in many cases are not in the normal range. So in this population, we also were picking up signal there. When in the right panel, what we did is we used metrics from the beam test, both the manual and saccadic metrics, to try and predict their performance on the cognitive battery that they completed. And what we saw here is that you can actually get pretty good prediction of overall cognitive performance just from beam metrics. So potentially, once clinically fielded on a wider scale, the beam test could be used as a cognitive screener that might facilitate cognitive assessment in environments where a full battery is not feasible. Importantly, validity of performance is really critical. One of the things about any performance test is that it requires effort. If somebody's not putting in effort to perform well, they're probably not going to perform very well. And if they're putting in effort to perform badly, then it's not that hard to perform badly. So the question is, what do you do to identify when a profile is good or valid and when it's invalid or it shouldn't be interpreted? And so back in 2016, David Barry and I published a study looking at a simulation study where we had a group of fake bad participants who were trying to fake bad or impaired performance, but trying not to overdo it. We had a best effort group who was just told to do as well as they could, and then the chronic mild TBI group in red. The upshot here is that we were very successful in separating out these groups based on saccadic metrics. The interpretation here is that because the time scale of measurement is so fast, that when somebody tries to fake bad on these measures, their performance gets blown way out of the normal or even out of the clinical range for a chronic mild TBI population, and it ends up in a implausible or invalid range. And so the goal here is just to be able to identify profiles that should not be interpreted and make sure that we can go back and get some good data later. So that does appear to be something that is facilitated by saccadic assessment as well. More recently, we've been doing work that I mentioned earlier to look at similar sorts of eye movements in military relevant environments, because we want to be able to use this information from the clinical tests to help determine return to duty, making sure people are returning to duty when they can, and that if they're not ready, that they're held back. So here's an example of the type of approach that we've used here, and I'll play a short video. So you can see the same sorts of cues are used. They're making eye movements to the left and the right, but here they're engaging visual targets or not engaging them based on the cues that are presented on the screen. And so these are service members with weapons training where this is part of their role and part of their responsibility is to be able to perform these types of duties. And when we look at certain aspects of their eye movements on this task, what we see is that they correlate strongly with those clinical tests. That's very important because we don't want to have to put every service member with a concussion through this multi-million-dollar VR environment. That's not remotely feasible. What we do want to do is be able to have scalable clinical assessments that can give us a sense of or a prediction of how they might do in a duty environment. And so that's why we conducted that work. You can see here on this slide that in the virtual environment, those no-go errors where they're looking at targets that they're not supposed to look at are elevated. So they're making more errors in the chronic mild TBI group relative to controls, even in this more complex dynamic environment where it's not just a simple eye tracking test, it's more something that's a little bit more realistic. So these do appear to translate. Thankfully, the manual errors, so incorrect trigger pulls, we have not seen those being elevated in our chronic mild TBI group. So this appears to be restricted to visual attention, but that could still be very important in time-sensitive real-world environments. Looking more globally at eye movements, we've been trying to understand other ways that eye movements might differ related to TBI in complex environments like that VR environment that I showed you. And we're seeing that in chronic mild TBI, we do have some big picture patterns of eye movements that differ. So they're spending less time fixating on targets and on cues, basically less time on target compared to controls, and they're executing fewer saccades overall. So it looks like there is maybe some distractibility as well as a restriction of visual scanning that is occurring in some individuals with chronic mild TBI. But we have some more work to do to try and understand that better and understand the conditions in which that's most likely to occur. But it doesn't appear to be restricted to any just one type of task condition, those types of effects. In terms of ongoing research, we are continuing to perform that virtual reality work in a longitudinal study where we're tracking mild TBI patients over time, both subacute mild TBI or recent mild TBI and chronic or more remote mild TBIs who are enrolled in rehabilitation settings to see what the trajectory of improvement or change looks like over time on these kind of metrics. And we're also looking at, in our Fusion military normative study, which is conducted in collaboration with Fort Liberty and Naval Medical Center San Diego, we're trying to establish really rigorously what normal performance looks like in uninjured individuals, as well as what effects of post-traumatic stress disorder, insomnia, and orthopedic injury might be, so that we can really tease apart any effects of things like pain and stress and sleep and other factors beyond brain injury that could impact performance. We're also looking at the trajectory of recovery in subacute mild TBI in that study. And then more recently, we've also been conducting a number of studies looking at how these fusion eye tracking metrics relate to MRI findings. I mentioned earlier on that clinical MRIs do not tend to be that useful for most mild TBI patients, but there's a variety of research scans that can give us information about structural integrity of the white matter, or such as diffusion tensor imaging, or about functional activity, how the type of neural resources the brain is using at rest or during cognitive tasks. And those are things that in MRI are not really valid for use with a single patient, but we can get reliable and valid measurement of a single patient using our neurocognitive eye tracking. So what we're trying to do here is index those eye tracking metrics against those research MRI findings. And we have some pretty exciting findings that I don't have time to get into today, but that I'll be presenting for those of you who are able to attend the Military Health Systems conference in August this year. I'll be presenting it there and then sharing it in a number of venues later, where we are seeing relationships between some of our key eye tracking metrics and MRI findings of white matter injury and other structural findings. So this is where we're at now. A lot more research ongoing in order to keep this moving forwards. Just to summarize what we've been talking about here, we've conducted a number of studies showing that neurocognitive eye tracking can be more sensitive than conventional cognitive tests to TBI-related cognitive and oculomotor changes. And those types of changes are most notable when someone is under a high level of cognitive load. So they may be doing completely normally on more basic eye movement type of evaluations. These oculomotor impairments do appear to be presenting in similar ways in simulated military operational settings as they do on our more basic clinical tasks. And so we're doing additional work to extend this work and expand these capabilities so that they can be applied within DoD clinical and operational settings. And I should take this moment also to mention that part of this work involves connecting with collaborators like some of the folks who may be in the webinar now, who are working in environments where they think these capabilities could be useful. The patent on this technology is a DoD-owned patent, and so DoD has rights to use this really any way that it needs to, and I'm here to facilitate that however I can. So we've got some references that I can provide to those who are interested. I wanted to acknowledge the many collaborators who've helped with this body of work here at Naval Medical Center San Diego, the Naval Health Research Center, Uniformed Services University, as well as support that we've received from the Defense Health Agency, TBI Center of Excellence, Uniformed Services University, and grant support from CDMRP. So here's my email for anyone who wants to follow up and have any questions that you don't have a chance to ask about today. But now it looks like we have a little bit of time for discussion and questions as well. So I will stop sharing my slides. Thank you.
Perfect. Well, thank you so much, Dr. Ettenhofer. That is a fascinating overview of something that I personally didn't know very much about. So thank you so much for that. And we do have several questions that have come in. So I will get started on some of them. The first one that came in is just how do you define penetrating? You're discussing a penetrating injury.
Good question. A penetrating injury is classified separately from mild, moderate, and severe. And this is when anytime that you have an open head wound, where most classically, if you have a bullet or a fragment of something that enters the skull, you've got a penetrating injury, and those can be quite different in terms of how they look and what's needed in terms of clinical care. Thankfully, they're also quite rare compared to other forms of injury.
Okay, and then I think you kind of answered this, but it might be worth reiterating is, are you saying that in MTBI, neuroimaging doesn't show evidence of a concussion?
The typical concussion will not show up on clinical MRIs that are performed in most settings. That's correct. There are some situations where someone who has what looks like a concussion receives a scan and where some sort of intracranial abnormality is identified. That is, by some people, then reclassified as a moderate TBI. Others outside of DoD and VA might call that complicated mild TBI, but the MRI is not a standard of care measure in most concussions, unless there's some indication that they're at risk for a brain bleed or a more severe injury or some other complicating factor.
All right, thank you. And then with the cognitive load testing and having the patient select targets, I'm assuming that it would require that they have a baseline test for comparison against. Is that correct?
Not necessarily. So as with cognitive test data that's more traditional, baseline data can be helpful if their performance is at baseline different than average. But one of the things that we see with eye tracking measures is that there's less variability introduced by some of those other factors. So within a non-elderly adult population, for example, we see very little in the way of age effects on most of the saccadic metrics. We see very little in the way of intelligence effects on those metrics, and that is worlds apart from what you would see on most cognitive testing, where age and intelligence are almost overwhelming. If you don't account for that or potentially other baseline factors related to pre-injury ability, then that can be difficult. But with eye tracking, we have an enhanced ability to compare them to other people to know what's normal and abnormal. But we'll be getting some more information about that with some of these large samples we're collecting now with the help of Port Liberty.
That's interesting, and I think that it might be a little bit related to the next question in a way. Are these tests and interventions meant to be implemented on recent TBI patients, or could they also be effective for those that have been suffering from TBI injuries for multiple years, such as veterans?
Yeah, great question. So most of our work was really born out of the chronic setting where we were seeing that we weren't getting the sensitivity that we were hoping for from these conventional neuropsych measures, where the recovery looked quite good, but patients were still reporting issues, and we wanted to understand that better. So that's really the seed of a lot of this work, is the chronic setting. However, we've been developing these more advanced platforms like head-mounted VR, low-cost platforms, so that they could be forward deployed, used in environments where an injury might have happened quite recently in order to pick those up as well. So that's with some of our subacute injuries that we've been doing a lot more recent research on. So really the answer is both, but most of our data so far is from the chronic setting.
All right, wonderful. And then next question, are there any relations to these eye movement studies and interventions to EMDR, which is eye movement desensitization and reprocessing, to EMDR therapy and TBI recovery?
Yeah, we get asked that a lot because there's some sort of reminiscent of EMDR, which is a type of therapeutic intervention that involves having people perform eye movements during various psychological interventions. And so I know some of those interventions have measured eye movements. I do think we're looking at something a little bit different here, but perhaps the common thread is that eye movements can be related to brain function in ways that are not necessarily obvious. And so to the degree that EMDR provides a way to help activate brain areas that wouldn't be activated if you're not moving your eyes, for example, there may be something similar at play where the eye movements that we're measuring and performing can activate brain areas that wouldn't necessarily be activated in other cognitive tests as well.
All right, and wow, a bunch of questions are still coming in, so rapid fire, here we go. These interventions seem effective for getting active duty front of the line enlisted personnel back into service as soon as possible. Has there also been inclusion of observations to improvements to the effects of depression, suicidal thoughts, or complex cognitive processing, or other mental health aspects of TBI?
So yeah, we have some colleagues who've been using similar techniques. We haven't seen the data yet, but have been using similar techniques to understand the potential impact of emotional psychological factors on visual attention. For example, instead of using cognitive cues like white and red arrows or colored targets, They may use faces that have expressions on them, and then seeing what the brain response is, perhaps in terms of like distraction or cognitive overload that could occur in cases of individuals who have heightened emotional response to different emotional situations, such as in PTSD. So we don't have the data yet, so I can't speak to exactly what that looks like, but it's definitely something that I think is important because mental health is a tremendously important consideration in terms of returning someone to duty beyond just their cognitive fitness.
Perfect. Did get a quick question. Somebody asked for the link or information for MHSRS, which is the Military Health System Research Symposium. So I responded to that person in the Q&A, but for anybody that is interested, it's mhsrs.net is the official link, and that conference takes place the 26th to the 29th of August down near Orlando, Florida. So I've been there the last couple years. It's where I came across Dr. Ettenhofer, and so it's a wonderful, one of the most interesting conferences I go to. But moving on to the next question, has any of this testing been officially rolled into Special Forces recovery programs?
We have not been using this clinically in special operations communities. Everything we've been doing so far has been in a clinical research type of context, but that's really one of our goals, is to start to transition these capabilities into different environments, both for clinical and operational use.
Okay, next question. Were you able to complete a trial with the VR beam test on the PICO system, PICO? If so, did you say that the Fusion VR test had similar results?
We are currently conducting research using beam and the Fusion NVAC tests and some other tests on the PICO system. The data that I showed today are from our laptop system and other systems that are similar to that laptop type system, because some of those studies were collecting EEG at the same time as eye tracking. And so for those, the VR headset isn't a good platform because of the way that it fits on the face and the head. But the performance characteristics appear to be very similar, but that's something that we're actually testing formally in some of our ongoing research to make sure that we're not introducing any major differences when we change platforms.
All right. Is it possible to accurately isolate the effect of an injury that could affect both the brain and the muscles or nerves responsible for controlling eye movement? This would be based on the proximity and mechanism of the injury.
Could you repeat the first part of that question again?
Is it possible to accurately isolate the effect of an injury that could affect both the brain and the muscles and nerves responsible for controlling eye movement? So I guess if both of those things were injured, can you isolate it using these tests?
Maybe. I do think that if you have problems with more fundamental eye movements and problems with musculature or triggering of the basic eye movements, that would be far and away the most obvious thing that you would see. And so, for example, if you had someone who actually was having difficulty making eye movements in certain directions or at certain types, that might manifest then. In that situation, it might be hard to know why their performance is impaired, but it kind of depends on their profile of impairment. So if you have a problem with the musculature of the eyes, it's not obvious off the cuff why cognitive load would matter. So you can look at their cognitive load profile. Do they perform similarly badly under low cognitive load and high cognitive load conditions? If so, maybe then the cognitive piece is not as prominent. On the other hand, the profile, I think, could bear a lot of interpretation, but I think the more data that we have, the more we'll be able to speak to those kinds of questions. So I think even though we've been using this in the context of mild TBI and sussing out some of those types of effects, I'm really curious for colleagues I have who work with stroke and MS and ADHD and all other kinds of brain conditions. I do think that you may be able to use similar approaches or the same tests, but looking at different profiles of impairment to understand what might be going on with those individuals. But our data is focused on TBI, so that's all that I'm able to speak to so far.
Great, thank you. So I think we only have time to get to one more question. We have one more very interesting one that I'd love to ask. And what I'll do, since you did have your email address up on the screen, I'm going to drop it in the chat as well. so that folks can maybe shoot you an email if they want to get in touch. The next and the last question I'll ask is, how do you account for color blindness and additional cognitive load for the red, blue, green signals in fusion NBAC assessments?
Great question. This is exactly what FDA asked us in our Q-sub meetings with them. And so our newer versions of that task use different colors that are compatible with the most common types of color blindness, so that we can still test people who have those types of issues without the red-green color blindness issue. So yeah, excellent question.
Perfect. Thank you so much, Dr. Ettenhofer. I'm going to end the Q&A there. Again, I dropped Dr. Ettenhofer's email address into the chat, so you can grab that. And you can always reach out to HDIAC, either submit a technical inquiry or just reach out at contact@hdiac.org, and we can help link you with Dr. Ettenhofer and other researchers in this area who we've been working with and kind of maintain contact with. And that's part of our technical inquiry service we offer to the community to help link folks that are doing this kind of research. But Dr. Ettenhofer, I have to say this was a very enlightening and interesting webinar and presentation. And I thank you so much for kind of closing out our brain health mini series today.
Thanks so much. It was a real pleasure, and looking forward to following up with folks afterwards as well. So hope everyone has a great afternoon.
Thank you.